Ho ho ho! Merry Christmas!
My name is Griselyn Veronica and my partner is Joyce Evelyn Consel, and we will be talking about PUD or peptic ulcer disease. So peptic ulcer disease is a disorder characterized by erosion or ulceration of the mucosal lining of the gastrointestinal tract due to the damaging effects of gastric acid and pepsin. These ulcers occur when the protective mechanism of the GI mucosa are impaired, allowing acid to injure the tissue. Parts of the body affected by PUD are stomach, duodenum, and less commonly the esophagus. Upper GI organs and functions are: first, we have esophagus, which transport food from the mouth to the stomach through peristalsis. We have stomach. It stores food, secretes hydrochloric acid and pepsin for digestion, begins protein digestion, and converts food into chyme. Next, we have duodenum. It receives chyme from the stomach, neutralizes gastric acid with bile and pancreatic secretion, continues digestion and nutrient absorption. Next, we have accessory organs which are related to digestion. We have liver. It produces bile for fat digestion. Gallbladder, which stores and concentrates bile. And pancreas, which secretes digestive enzymes and bicarbonate. Types and causes of PUD. First, we have gastric ulcer, which occurs in the stomach. Common causes are Helicobacter pylori infection, chronic use of NSAIDs, alcohol intake, smoking, stress and gastric mucosal damage. We have duodenal ulcer, which occurs in the duodenum. Common causes are pylori infection, hypersecretion of gastric acid, smoking, and genetic predisposition. Next, we have esophageal ulcer, which occurs in the esophagus. Common causes are GERD with prolonged acid exposure, use of irritant medications such as NSAIDs, potassium chloride, or bisphosphonate, severe vomiting or mechanical injury, and infection, especially in immunocompromised patients. Next, we have stress-related ulcers, which seen in critically ill patients, caused by severe physiologic stress, such as burns, trauma, or sepsis. We also have drug-induced ulcers due to NSAIDs, aspirin, and corticosteroids. These drugs inhibit the prostaglandin production, reducing mucosal protection. And we also have Zollinger-Ellison syndrome, which caused by gastrin-secreting tumors or gastrinomas, results in excessive gastric acid secretion, leads to multiple recurrent and treatment-resistant ulcers. The characteristics and symptoms of gastric ulcers and duodenal ulcers. For gastric ulcers, it's located in the stomach, occurs soon after eating, pain worsens with food, uncommon for the night pain, and usually weight loss occurs, and for the acid secretion, it's normal or low. And for duodenal ulcers, it is located in duodenum, occurs 2 to 3 hours after meal, pain relief by food, night pain is common, weight gain due to frequent eating to relieve pain, and the acid secretion is increased. For the complications, we have gastrointestinal bleeding. It is the most common complication manifested by the hematemesis, melena or anemia. Next we have perforation. Ulcer erodes through the stomach or duodenal wall, leads to peritonitis and is a medical emergency. We also have gastric outlet obstruction, which caused by inflammation, edema or scarring, results in vomiting, abdominal distension, and dehydration. We also have penetration. Ulcer extends into adjacent organs, such as pancreas, which cause severe persistent pain. And the last we have malignancy or gastric ulcer. Some gastric ulcers may become cancerous if untreated.
For question number 7, the question is, what medications are included in the treatment of ulcers, and how do these drugs benefit the patients, and why are they given? So for medications, we have the PIPs, we have the proton pump inhibitors. So under the PIPs, we have omeprazole and pantoprazole. This reduces gastric acid, and this promotes ulcer healing. Then the next medication would be H2 receptor blockers, which are famotidine and cimetidine. This one decreases the acid secretion. Then we have antacids. This neutralizes the existing stomach acid for symptom relief. And then next we have the antibiotics, which are amoxicillin, clarithromycin, and metronidazole. So this one eradicates infection that causes ulcer. Then next we have the mucosal protectants, which are sucralfate and bismuth. For this one coats and protects the ulcer surface. Then we have the prostaglandin analogs. Under this one we have misoprostol, which prevents NSAID-induced ulcers. So why are this medication given to our patients with peptic ulcer disease? The reason is that this helps to reduce the acid, to eradicate infection, protect the mucosa, relieve symptoms, and prevent the complications. Alright, for question number 8, we have to identify the different surgical interventions for the treatment of peptic ulcer disease or PUD. So how are these surgeries done? First, we have vagotomy. So one of the surgical interventions is vagotomy, and this one reduces the acid secretion by interrupting vagal stimulation to the stomach. Then we have antrectomy. This is the removal of the antrum, which is the gastrin producing part of the stomach. Next surgical intervention, we have biliaroplasty. This one is the widening of the biliaries to improve gastric emptying. Next, we have partial gastrectomy. This one is the removal of the ulcerated stomach portion. Next and last, we have the repair of perforated ulcer, suturing the perforation. And oftentimes, this is an emergency surgery. So all of these surgical interventions can be open or laparoscopic, depends on the severity and the condition of the patient. Then we go to our question number 9. Identify problems related to peptic ulcers, and as a nurse, what would you do to prevent or manage these problems? So first, let's start with the common problems of peptic ulcer disease. We have GI, bleeding, perforation, gastric outlet obstruction, pain, infection, and malnutrition. For nursing interventions, we have a lot, so let's start with number one. First, we have to monitor the vital signs and the signs of bleeding or hematemesis or melena. Then, we have to administer medications as ordered. These are the PPIs and antibiotics. Number three, we have to educate our patient to avoid NSAIDs, smoking, and alcohol. Next one, we have to encourage small and frequent meals, monitor hemoglobin and hematocrit, provide pain management, promote adherence to H. pylori treatment, and lastly, we have to observe for signs of perforation. So, what are the signs? This could be a sudden severe pain and a rigid abdomen. So, for question number 10, we have to look and search for recent advances in peptic ulcer disease prevention, diagnosis, and treatment. So, we found three studies about this. First one is found in PubMed 2025. Then we have the Exploration Publishing. This one is 2023. And the other one is Synapse. This is also 2025. So for the summary of these studies, the recent, I'll be reading it. The recent scientific literature highlights several innovations improving how peptic ulcer disease is diagnosed, managed, and possibly prevented. A growing body of research emphasizes advanced diagnostics that enhance accuracy, speed, and actionable insights into Helicobacter pylori infection, which is the primary contributor to peptic ulcers. Beyond traditional methods like urea breath tests and stool antigen testing, next generation technologies such as biosensors, microfluidic devices, and molecular assays, which includes rapid PCR and potentially bacteriophage based tools, are under investigation to detect the H. pylori more sensitively, rapidly, and non invasively, which could allow earlier diagnosis and tailored treatment decisions. That's from PubMed. And in terms of management and treatment, the landscape is shifting due to increasing antibiotic resistance. Standard combination therapies are being refined with individualized strategies that consider patient's genotype, bacterial susceptibility, and antibiotic stewardship to maximize the eradication success while limiting resistance of development. Adjunctive approaches, including probiotics, have shown promise in enhancing eradication rates and minimizing side effects when used alongside conventional regimens. Moreover, the potassium competitive acid blockers or PCABs like vonoprazan and tegoprazan are emerging as alternatives to traditional PIPs, PPIs, offering faster and more sustained acid suppression with strong healing outcomes, according to Exploration Publishing. And on the prevention front, global clinical trials and public health efforts underline the benefit of widespread screening and eradication, particularly in high risk populations, to reduce peptic ulcer complications and downstream risks such as gastric cancer. Personalized medicine, including biomarker guided therapies and genomic profiling, is anticipated to improve prevention by identifying individuals who may benefit most from early treatment or monitoring. And altogether, these research advancements point toward precision strategies in diagnosis, multifaceted treatment regimens, and targeted prevention programs, aiming to reduce the global burden of peptic ulcer disease. So that is all for our topic, PUD or peptic ulcer disease. Thank you.